The Active Phase of Labor, a presentation of the American Journal of Obstetrics and Gynecology. The active phase begins when the rate of dilatation transitions from the relatively flat slope of the latent phase to a more rapid linear slope that is maintained until near complete dilatation. The degree of cervical dilatation reached at the start of the active phase varies considerably among parturients. The active phase ends with an interval, usually brief, of apparent slowing of dilatation called the deceleration phase. The lower limits for the normal rates of active phase dilatation are about 1.2 centimeters per hour in nulliparous and a more rapid rate of 1.5 centimeters per hour in multiparous. Plotting serial vaginal examinations on a square-ruled grid, as shown here, allows accurate identification of the beginning of the active phase and prompt recognition of dysfunctional labor progress. The abnormal dilatation patterns diagnosable during the active phase include excessively slow dilatation, called a protracted active phase, in which there is steady progress in dilatation, but at a rate below the limit of normal. An arrest of dilatation is diagnosed when, once the active phase has begun, progress in dilatation ceases for 2 hours. A prolonged deceleration phase is verified when the time to advance from about 8 centimeters to full dilatation exceeds 3 hours in a nullipara or 1 hour in a multipara. In addition, a failure of descent may sometimes be recognized in the terminal portion of the active phase when descent has not begun by the time the deceleration phase is underway. Whenever an active phase disorder is recognized, a thorough evaluation for contributing or causative factors is necessary. These may include cephalopelvic disproportion, excessive anesthesia or analgesia, and insufficient uterine contractility, as well as uterine infection, obesity, advanced age, prior cesarean delivery, and fetal malposition or malpresentation, and uterine overdistension. Identifying these factors is important in guiding therapy. When an active phase disorder is identified, cesarean delivery is justifiable if there is compelling clinical evidence of disproportion. Oxytocin infusion is effective in curing an arrest of dilatation in most cases when clinical evidence of disproportion is absent. It is less effective in the treatment of protracted active phase unless inhibitory factors are present. The primary clinical importance of the arrest of active phase is its strong association with cephalopelvic disproportion and its associated risks. Fully 40 to 50% of women with arrest of active phase have concomitant disproportion. A smaller number, roughly 20% of women with a protracted active phase, will require cesarean delivery for disproportion. Therefore, thorough clinical cephalopelvimetry is required in all cases. It is better to err on the side of intervention by cesarean in the presence of uncertainty about the safety of vaginal delivery. Most arrest disorders will respond to oxytocin infusion with additional progress in dilatation within 2 to 4 hours, and it is rarely necessary to administer the drug for longer than that. If the arrest disorder responds to oxytocin with a post-arrest slope of dilatation that is equal to or greater than the pre-arrest slope, prognosis for normal delivery is good. If, however, after 2 to 4 hours of oxytocin, there has been no change in dilatation, or the post-arrest slope is less than the pre-arrest slope, Or if cephalopelvic relations are worsening, the prognosis for vaginal delivery is poor. As noted, the limits of normal for the deceleration phase are 3 hours in nulliparous and 1 hour in multiparous. But astute clinicians will often recognize a potential problem even before these limits are reached, especially if abnormal fetal position or excessive molding are noted on examination. A prolonged deceleration phase is strongly associated with cephalopelvic disproportion, second stage abnormalities, and, if vaginal delivery eventuates, with shoulder dystocia and its associated risk of brachial plexus injury. The common causal pathway underlying many dysfunctional labor patterns probably involves impairment of normal uterine contractility. With this in mind, some approaches to the identification and treatment of abnormal labor depend on continuous measurement of uterine contractility via an intrauterine pressure transducer. While it may seem appealing to use this approach to define the adequacy of contractions, existing studies have failed to prove the virtue of this tactic, probably because there is a very broad spectrum of uterine contractility patterns associated with both normal and dysfunctional labor progress. As a consequence, the ability to distinguish between adequate and inadequate contractility has proved elusive. Montevideo units, the sum of uterine contraction amplitudes in a 10-minute period, are the most commonly employed quantitative measure. However, the correlation between Montevideo units and progress in dilatation is poor. We generally recommend against using quantitative intrauterine pressure data in decisions about the use of oxytocin. Clinical practice guidelines for the assessment and management of labor were issued by the American College of Obstetricians and Gynecologists and the Society for Maternal Fetal Medicine in 2014. These were based in part on the findings of Dr. J. Zhang and colleagues, whose analysis of cervical dilatation data suggested a pattern of change in labor quite different from that which had been accepted since the mid-1950s. The main objective in creating these guidelines was to reduce the insupportably high cesarean delivery rate. Since they were first introduced, however, the guidelines have not been shown to be consistently beneficial in diminishing cesarean delivery rates, and questions about their safety for mother and fetus have arisen. No studies have been done to assess whether following the guidelines could be associated with long-term harm. Moreover, concerns have been raised about the value of the complex statistical analyses that underlie the new labor patterns. In addition, the guidelines expressed no concern about how condoning much longer labors would affect the mother. The guidelines also do not require any form of evaluation of the cephalopelvic relations, and they do not provide consistent management algorithms. Based on the best available evidence, we have developed a paradigm for the diagnosis and management of active phase disorders. It requires accurate identification of the disorder, followed by thorough evaluation to identify cephalopelvic disproportion or other contributing factors. Then, a reasoned decision about whether or not to use oxytocin can be made, leading to a determination of when cesarean delivery is prudent. Adherence to this protocol will result in a uniform and rational diagnostic and treatment system and a reasonable cesarean rate.